Welcome, everyone. Welcome to this session for the APSC Cloud Forum of Cardiovascular Disease series. Today's topic is contemporary management of acute or chronic aortic dissection and aneurysms, a catastrophic aortopathy. This session is organized by the APSC. The date stamp today is 16th of June on a Wednesday, 2 p.m. Singapore time. A quick introduction to the session. We know that acute aortic dissection and chronic aortic aneurysms are the two aortic diseases with catastrophic outcomes. Different etiologies, atherosclerotic or Marfans, and different pathophysiologies lead to different clinical course in aortopathy evolution. With the current revolutional improvements in stent technology, transcatheter endovascular aortic stenting is really reshaping early as well as long-term prognosis of acute aortic dissection, chronic aortic aneurysms, and aortopic emergencies. However, early detection by imaging, prevention of aortopathy, progression or recurrence, and choice of open surgery versus transcatheter endovascular intervention remains critical decision points, particularly in Marfan's syndrome and other genetic connective tissue diseases. I hope to learn from the panel of speakers today about this spread of aortopathies. My name is Jack from Singapore, the current president for the Asian Pacific Society of Cardiology, as well as the president for the ICP. I'm very privileged to have my co-chairperson for session 2, Dr. Aaron Wu. He's a cardiac surgeon at the National Taiwan University Hospital from Taipei, Taiwan. Our first speaker is Dr. Wura Wong. He's also a cardiothoracic surgeon from the Faculty of Medicine, Sirarich Hospital, Mahidol University, Bangkok, Thailand. He's going to talk to us on surveillance and prevention of acute or chronic aortic dissecting aneurysm, except Marfan syndrome. This will be followed by Dr. Laszlo Gobolos from Abu Dhabi, UAE, at the Head and Vascular Institute, Cleveland Clinic, Abu Dhabi. He's going to follow on to talk about the approach and timing of management for acute or chronic type A aortic dissection and aneurysm. Our third speaker for session 1 will then be Dr. Wu. He's going to talk to us on the contemporary management of type B acute or chronic aortic dissection, except Marfan, the approach and timing of management. In session 2, chaired by Dr. Wu, we'll start off with Dr. Jack Chung from Singapore General Hospital, Singapore. He's going to speak to us on the surveillance and prevention of acute or chronic aortic dissection aneurysm in Marfan's syndrome. This will be followed by Professor Takeda from the University of Tokyo Hospital, Japan. He's going to follow up the lecture on contemporary management of acute or chronic aortic dissection and aneurysm in Marfan syndrome, the approach and timing of therapy. Our last but not the least speaker is Professor Ra from Korea. He's going to finish up by speaking to us on the contemporary management of abdominal aortic aneurysm, the approach and timing of therapy. A disclaimer, the content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. The content is currently made live stream via the APSC Cloud, Wonder, as well as the APSC Facebook and YouTube pages. So without further ado, let's get started. I'm excited to hear from Dr. Wura Wong on how do we survey and prevent the onset of acute or chronic aortic dissection. Dr. Wura Wong, please. So perhaps you can unmute yourself first. Dr. Wurawong, do you mind if you unmute yourself? Dr. Wurawong, can you unmute?
Oh.
Yeah. Okay,
Hello.
go ahead, please.
Just a second. Let me see my slide.
We can see your slide quite
Okay.
clearly now. Yeah, please go ahead.
Okay. Good afternoon. First of all, thank you for the organizing committee to invite me to present the topic in this webinar meeting. My topic will be the survey and prevention of acute and chronic aortic dissection aneurysm. This is our team from Sri Raj Aortic Center in Bangkok, Thailand. My topics today will be acute aortic dissection, nature, and chronic aortic dissection, and then survey and prevention. So this is a classic definition of the aortic dissection. We separate into Stanford type A and type B, which is the type A is include the ascending aortic involvement, and type B is not include the ascending aortic involvement. And also there are classification of acute aortic syndrome in the aortic dissection. By class 1 is a classical aortic dissection, which we will focus today. So there are a lot of the definition of the acute and chronic dissection. By classical is we use the 2 weeks to separate acute and chronic. But after the era of endovascular treatment, we found that there should be the subacute phase. So in the APSC guideline, they use the 2 weeks to separate the acute and subacute, and then after 3 months to be chronic dissection. In the IRA study, they add up the hyperacute dissection that is acute within the 24 hours. And then they use 1 week to divide between acute and subacute dissection, and use 1 month to separate the subacute and chronic dissection. And normally in our country, we follow the ESC guideline by use 2 weeks and 3 months to separate the acute, subacute, and chronic dissection. The study from the International Registry of Acute Aortic Dissection, or IRAD study, published in 2018. In their study, they show that classify between the type A and type B dissection. Demographics, they use the age and found that the type B dissection had the older age than the type A dissection. And also for type A dissection, the majority of male more than the type B dissection, but not significant different. And in that study, the majority of the patients are white patients, and just some of the Asian countries. The type B dissection found more hypertension than the type A dissection, and more atherosclerosis, and more aneurysm history, and also more the previous aortic dissection and previous cardiac surgery, AVR and aneurysm and dissection together more than in type A dissection. And they found that majority of the patient had the size of the aorta more than 5 centimeters. However, in the type B dissection, 21% of the patient had the aorta less than 3.5 centimeters. And they showed that the mortality in the type A and type B is big difference. The type B had a better prognosis than the type A dissection, as we know. There's interesting study about the circadian and season variation in the type A and type B dissection. And in that study, they found that majority of the patient had the high incident in the morning. You can see that in the table, the 37% of the patient develop acute dissection in between 6 to noon. And you can see that mortality is higher in the early morning after midnight to 6 a.m. And the study showed that the in-hospital clinical event is not different between time. How about in the different seasons? The study showed that the incidence is higher in the winter, which is we usually found in our country also. And this is a study from a Japanese group. They collect the data of the aortic dissection patients in 3 years and a lot of the type A dissection. Also, the study showed that the winter had a high prevalence of the acute dissection more than other season, both in type A and type B dissection. However, the mortality is not different between seasons. In the type A dissection, you can see for the Japanese found that the higher incidence of the mortality in the spring. They explain that probably because it's, the spring is the fiscal year, so there's a rotation of the surgeon to other hospital during this period of time. So probably that is the high incidence of the mortality. The clinical presentation and complication between type A and type B, there are some different. Type A show symptom of chest pain more than type B. Type B have back pain more than type A. And the complication for the type A, which usually include the aortic root, for example, the aortic regurgitation, tamponade, and myocardial ischemia, and also have a high incidence of the acute renal failure. So when we compare between the Japanese study and the IRAD, which is in the European country, the Japanese had a high incidence of the old patient, almost 70 years old, while the IRAD study is 61 years old. And in Japanese patients, the high incidence of the female patients. In the type A, the open surgery is around 66%, whereas in the IRAD study is high up to 86%, probably because of the high incidence of the OH patient in Japanese patients, so they have less open surgery. However, the operative mortality is better in the Japanese patients. For the type B, you can see the high incidence of the TIVA treatment in the IRAD study, whereas in the Japanese, they just start to use the endovascular treatment to treat their type B dissection. This is data from the IRAD study in the acute type A dissection. The surgical treatment still the main standard treatment in acute type A dissection. And the mortality is quite stable, a little bit lower in recent year. For the type B dissection, the treatment of the endovascular option is increasing year by year. However, the mortality is still not big difference between periods of time. So if we look at the type A dissection, we found that the surgical management have the much better survival than the medical treatment. For the type B dissection, The endovascular treatment had the best survival more than medical and surgical treatment. Let me share our experience for the acute type A dissection in our hospital. We collect the data from 2006 to 2018, and the primary type A dissection is 225 patients. Mean age 58 years old. Male is 62%, 80% is hypertension. And also the chest pain is up to 76%. 72% of the patients are the Becky type 1, which is include ascending arch and descending aorta. The size of anti-trash found in the ascending aorta up to 75%. For the procedures, we do the ascending aortic replacement in 36% and hemi-arch replacement in 34%. Total arch replacement is up to 22%. Concomitant procedure is aortic root procedure is 13% and frozen infant trunk 6%. In hospital mortality in our series 8.7%. Cause of death are cardiac problems, stroke, and sepsis. We had a high incidence of the acute kidney injury up to 62%, but the patient who had hemodialysis is 12%. Stroke rate is 12%. We found that the factor associated with the mortality is acute kidney injury that need hemodialysis. The odds ratio is 6. Persistent neurological deficit is 3.3 odds ratio, and prolonged bypass time is also the risk factor of the mortality. We compare the total arch replacement and non-total arch replacement, but we don't find any difference in mortality. But we found that the persistent neurological deficit is higher in the total arch patient. For the acute type B dissection, in our hospital, we separate into complicated and uncomplicated. Complicated type B dissection, majority we perform TIVA. In case of we cannot do the TIVA, we do the open surgery, and we found that survival is 82% for open surgery, 92% for the TIVA. For uncomplicated patient, we use the medication and also the TIVA and found that all of the patients survive in both groups. So, acute aortic syndrome in Thailand, we collect the data from 6 big hospitals in Thailand. The number is around almost 40% of the number of Thailand thoracic aortic surgery. Majority of the patient of dissection is type A dissection, up to 72%. So we collect the data average 8 years. The number of type A is 586 patients, type B uncomplicated 119 patients, and complicated 111 patients. For the procedures in type A dissection, most of the procedures are ascending or hemi-arch replacement. The total arch replacement is only found in some big hospital, and mortality is vary between the high volume center and low volume center. So it starts from 8 to 7% up to 27%. For acute complicated type B dissection, majority of the center do the TIVA up to 83.8%. For uncomplicated type B dissection, also all center do the TIVA up to 86 to 68%. So we collect the data this year in the 12 hospital in Thailand, and the majority of the patients acute type A dissection, 31% acute type B dissection. The age is vary in the acute and chronic dissection. In chronic is much older than the acute dissection. When we compare to the Japan and Iran study, we found that we do the open surgery in type A dissection much more than the Japan or Iran study. We performed up to 98%, and operative mortality is 15% in our country. For acute type B dissection, we perform open surgery in 12% and TIVA up to 73%. The operative mortality is around 7%. This is comparable to the other country. For the chronic type B dissection, so 25% of the acute type B dissection survivor will die within 3 years, and 60% of uncomplicated type B dissection will develop aneurysm change even we use the best medical therapy. This is data from the ARA study found that the aortic expansion up to 1.7 millimeters per year, and the diameter 6 centimeters will rupture 30% per year. So option of the chronic type B dissection, the medical treatment, open surgery, or endovascular surgery. To prevent this event by medication, beta blocker and calcium channel blocker is improved survival. And we used to keep the blood pressure lower than 130 over 80 millimeter mercury. For losartan can slow aortic enlargement in the Marfan syndrome. Lifestyle modification, we discourage to use the competitive sport or weight lifting. And surgery, some operation, for example, endovascular repair in high-risk uncomplicated acute type B dissection may prevent the chronic dissection in the future. And aggressive surgery by do the total arch replacement plus frozen infant trunk can prevent the future aneurysmal change in the future for the big type 1. This data showed the beta blocker improved survival when compared to the patient who did not use beta blocker. The indication for chronic type B surgery is diameter and rate of growth and also the symptom. Open surgery is a choice in the fit patient. The endovascular repair is a class 2B recommendation in 2010 from the AHA guideline. But in the EVS guideline in 2017, the endovascular repair can be class 2A recommendation in dedicated center. However, there's some problem in the chronic dissection because the true and false lumen is different in size. There's some partial or thrombosed false lumen. In some patients, there's a big false lumen. And there's mismatch between proximal and distal size of the aorta. And the dissection flap is thick. And sometimes there are multiple re-entry size. There are some techniques try to improve and prevent the future enlargement. The follow-up protocol is very important. So some recommend to do the CT scan and MRI to follow up the patient. Both open repair and endovascular repair by the protocol that recommend from the guidelines. So in conclusion, the incidence of acute dissection is highest in winter, and surgery is the best management of acute type A dissection. Best medical therapy is the main treatment for uncomplicated type B dissection. Endovascular repair is standard treatment in complicated type B dissection and may prevent future complication in uncomplicated type B dissection. Long-term follow-up is mandatory for chronic aortic dissection patients. Thank you for your attention.
Thanks, Dr. Wurong. That was indeed a very exhaustive lecture, and I really appreciated you sharing the Thailand data. It was very, very interesting to me. So perhaps we can take a discussion around the region before we move on to Dr. Gobelow's lecture, also on a similar grain. Your topic initially was surveillance and prevention. So perhaps I can ask a few questions on top of my head. Was that I saw that in Thailand, it seems that you had a lot more type A than type B. I wonder,
Yes.
what do you think is the main cause of that? Because we see generally more type B than A. And perhaps I can start with Dr. Ra, if you're online. Dr. Ra from Korea. If not, can I ask the first question to Dr. Wu then from Taiwan? I saw in Dr. Wu Wang's data, about 10% of the patients had concomitant bypass surgery for type A dissection repair. What is your practice? Do you ask a cardiologist to go in for coronary angiogram for type A dissection, or what is your guidance on that, Aaron? Do you need a coronary angiogram for type A dissection before emergent surgery?
You mean?
Yes, Dr. Wu?
Oh, yeah. No, definitely not. For the type A dissection, no, definitely not. So actually, the incidence that we are doing the concomitant coronary artery bypass in patient with acute type A is very, very rare, unless you cannot really wean off the bypass, or you found the dissection flap really compromise the left coronary artery or right coronary artery on site. When you open the aorta to replace that, and then you found that you have a really intimate dissection, and with the really compromise the coronary artery by the surgeon seeing or decision. But the chance is very, very low. We don't routinely do the coronary angio unless it's really misdiagnosis in the ER as acute coronary syndrome patient, and getting to the cath lab, and they found that it's a acute type A dissection. So it's vice versa. So it's not actually because the patient had acute type A dissection and we are doing the coronary angiogram. No, that's rare.
So thanks for saying that, Dr. Wu. I just want that for cardiology audience, because I think sometimes some surgeons do request for angiogram. I would like to ask Dr. Ra then, what is practice in Korea regarding when does a cardiologist like yourself refer a dilated aorta to the surgeon? When do you think is the appropriate moment or size? And what are the factors that you think of?
Actually, all the elective aneurysm case, especially undergoing elective intervention, TEVA case, 100% we are doing the coronary angiography, because as you know, the cerebrovascular disease and coronary disease, compared to the control patients, the incidence of aneurysm is higher in the symptoms of the CAD disease patients. So the prevalence of CAD is, of course, higher than the control patients. So not only this aneurysm patients, the peripheral usual ASCVD peripheral patients, our patients, the undergoing peripheral angioplasty, to me, especially CLI patients, approaching 67 to 70 patients who are undergoing coronary stenting together. So many of them, the final cause of death is going to be coronary disease. So elective angioplasty, in elective aortic intervention patients, we are routinely doing the coronary workup together at on site during the aortic intervention. However, the complicated aortic intervention, like the Dr. Wu in that kind of emergency case, unless there's a really previous history of symptoms CAD, or the really symptomatic case, or the hemodynamic instability due to coronary, really for example, the echo finding of a regional wall motion abnormality definite something trouble or cardiac enzyme elevation, ECG change, or dynamic occlusion evidence. In that case, we have to do something, but otherwise, that will not be routine case, emergency case. However, not complicated case, basically cardiologists always focus on the coronary first, including TAVI also. Every aortic intervention or valvular intervention, routinely at least we have to do CT angiography to check the coronary anatomy.
Thanks, Dr. Ra. So the advice is that it is truly urgent and life-saving. Yes, Dr. Wu.
One question that I can pose to Dr. Ra. Yeah, because of I think if you do the coronary routine, do the coronary angioplasty, do the coronary angiogram before the elective, we so-called the elective aortic aneurysm surgery, and once you decided to put in the stent, which kind of stent you put in? Because of I think with the drug-coated stent or whatever stent, you really need to have the dual tablet on board and then really delay the surgery of the elective aortic aneurysm. So that's what I'm interesting.
Yeah, these days no problem. Recently, just one published data. Recently published the 6 months post-PCI elective aortic intervention will be safe. Is the only one published data. However, recent current generation drug-induced stent, as you know, the many Korean randomized clinical data published in the Lancet, even ACS status, 1 month to 3 months DAPT after dual antibiotic, then switch it to monotherapy, and even the 5 to 7 days discontinuation, then doing the major surgery. In general, no problem. So 1 month DAPT, stop DAPT, everything these days similar to bare metal stent. So we are not so afraid of that kind of situation. However, really, for instance, 70% stent, 80% stenosis, but we are expecting major surgery, including this aortic surgery. We try to postpone the PCI, expected surgery, just medical therapy, doing the aortic surgery first. It's the expected surgery, just not really, this patient is really pending MI, then we have to do surgery. We have to do PCI first because we are expecting really critical narrowing, then pending infarct, something like that event. However, if that is not so critical, just we have to postpone PCI, then doing the aortic surgery or EVA first, then we have to postpone 3 to 6 months later. Then, so it depends on the situation. However, even we didn't realize that this patient require aortic surgery. However, we already have done the PCI first, then found this patient really need the aortic intervention due to the rupture risk or the secular aneurysm expanding, something due for the aorta. However, already underwent PCI. But really, 1 month, 3 months, that will not be so trouble with the current generation drug-induced stents. That is my opinion.
Thanks, Dr. Ra. So I think also a hard team approach. I just want to go back to the data shared by Dr. Wong. He showed a really huge number of type A versus type B in Thailand. So I wonder whether anyone has some experience to share, whether it's the same in Japan, Singapore, or Korea, or Taiwan. Do you have so much more type A than type B, acute aortic dissection?
I think we had more type A than type B, that's for sure. But the incidence is about half and half, but not as the most, not like 70-80 like this. No, about half and half. Yeah.
Can I ask Dr. Wong then, what do you suspect is the reason in Thailand? Is it because the type B doesn't present, or is it because the incidence truly is higher, more aortopathy or more uncontrolled hypertension in Thailand? What is your speculation?
I think probably the is the high incidence of the hypertension patient in the young patient who are very active and poor control medication. Actually, I think the number of the type B is not so high in our country, and but usually both type A and type B is come to the surgical department for management, both medication and surgery or intervention, whatever. And that is the number that we found. The type A is really high incident.
Yeah. But I think in our experience, that type A is a little like a 10 to 20 years younger than the type B. So usually the type A is around the 50 to 60, and the type B is about 70, more than 70 to 80. So basically, I think it really depends on the age, prevalence, distribution in the country. So I think in the old age area, that should be more type B than the type A. I think it's because there's an age difference.
So you're saying Thailand may look forward to seeing more type B later on as a population ages.
It's a more young population probably in Thailand.
So maybe one last comment from Professor Takeda. I think your data in Japan was contrasted. The pattern in Japan, is it half-half as well?
I'm sorry?
The percentage between acute type A and type B. In Japan, you have a more elderly population subgroup. Do you see more type A or type B acute aortic dissection?
Actually, I'm sorry. I have the exact data now, so I'm sorry.
No problem. We're going to then move on and transit to Dr. Gobela's talk. He's going to talk to us on management, and there'll be some overlap with Dr. Wurawong's talk, but Dr. Gobelas, please.
Thank you very much. Yes, I believe there will be a little bit of overlap. Thank you.
So, Timothy, are you playing the recorded lecture? Yep, thank you.
Dear APSC chair panel, ladies and gentlemen, thank you very much for the invitation to present about the contemporary management of acute type A aortic dissection. No conflict of interest is present to be declared. On this slide, the list of applied abbreviations is displayed. Aortic surgery has undergone significant changes in the past 2 decades, leading to major improvement in short and long-term outcomes, better understanding of underlying diseases, improved guidelines and classifications have contributed to more effective prompt diagnosis and treatment. New imaging modalities, evolvement of perfusion methods, intra- and postoperative monitoring, improved intensive care are also of importance for achieving favorable outcomes. Development of cardiac surgery itself is perhaps the most important component of this evolutionary process. Despite of all, further refinement is required in our techniques and approaches to tame this devastating disease, as was pointed out by Bob Bonzer and other pioneers of aortic surgery. In a state-of-art paper published in JACC, approximately 10. The central illustration of the paper shows not only the most widely applied classification, the Stanford classification, that also carries some instant therapeutic hints, but the main challenges that a cardiac surgeon faces, namely brain and coronary malperfusion, pericardial tamponade, acute aortic valve regurgitation are also visible here. Acute aortic syndrome became a widely accepted term. As a definition, acute aortic syndrome is an acute pathophysiological process involving the tunica media of the aortic wall, which results in rupture or any further life-threatening complications. aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer are belonging to this pathophysiology. 30 persons per 1 million per year is the incidence of the disease, of which 80% is aortic dissections. The typical patient is a 60 years old male, and the disease has a peak frequency in the morning hours, usually in the winter time. Mortality of the disease is fairly high. 20% of the patients die before reaching the hospital, 30% during the hospital stay, another 20% in the following 10 years, and this data is deriving from a large-scale Swedish database. The impact of perioperative hemodynamic instability on early postoperative mortality is well demonstrated by a figure of the previously mentioned Bonza paper. Hypotension or shock results in 3.81-fold of risk elevation. A meta-analysis by Wesseling from Utrecht University in Netherlands, consisting of 42 publications, pointed out that MAP values under 80 millimeters of mercury over a duration of only 10 minutes significantly increase the risk of end organ injury. And if the MAP is under 55 millimeters of mercury, instantly will lead to adverse outcomes. Therefore, optimized diagnostics and therapeutic approaches save time, and with that reduce the rate of possible complications. A current consensus document of the AATS under publication in the JTCVS helps me to support the main points of surgical approach in the management of type A aortic dissections throughout the presentation. This topic was under intense discussions on conferences and in papers over the past 2 decades and has been summarized in the current guidelines. The central message of the document immediately shows 2 novel considerations for type A aortic dissections: the suggestion of central and axillary cannulations in contrast to the classical femoral approach, and the second, that end organ malperfusion may have to be treated earlier than the proximal aortic repair. The guidelines provide suggestions not only for the definite surgical pathways, but preoperative management and transport targets. Optimal medical management reduces shear stress on the diseased aortic wall, slows down process progression, hence reducing the probability of devastating complications, including aortic rupture or further extension of dissection. The importance of specialized aortic centers is also emphasized. The 30-day post-procedural mortality is showing a high contrast with 10 to 12% in these selected centers in comparison to 30% of a non-specialized low-volume cardiac unit. Emergency surgery is recommended in type A aortic dissection due to rapid progression capability of the disease. However, currently there are active discussions on the exact timing in the aortic community. The background is, as shown in earlier slides, that most type A aortic dissections occur at 8-9 o'clock in the morning, but due to patient factors, transport availability, accident and emergency, and diagnostic delays, these patients get on the table late evening or in the middle of the night. Several aortic groups have proposed for this very reason to delay somewhat the surgery until early morning in stable patients. Hence, the better resources result in more advantageous outcomes, and 5-6 hours of difference in procedure start might be tolerable, and it still falls within the 24 hours emergency category. However, there is no clear consensus about this. The current guideline suggests surgery for intramural hematoma in high-risk cases. The high-risk features are visible in the bottom line of the slide. My opinion is that under 70, surgery is the treatment of choice. Expectant management can be justified in elderly with comorbidities on board. Brain malperfusion is not a contraindication. We restore blood flow and give a survival chance for the patient with surgery. Limited iatrogenic type A aortic dissections might be managed conservatively, and retrograde type A aortic dissections may resolve with interventional approach of the type B dissection entry point. Restoring antegrade perfusion and reducing the risk of embolism is the main aim of surgery in type A aortic dissections. The classical femoral approach is mainly reserved for emergency peripheral cannulations, since the risk of retrograde embolism and extension of malperfusion. After 15 years of extensive debates, central cannulation became a valuable surgical asset in the procedures. Antegrade cerebral perfusion is the neuroprotective method of choice, although the guideline accepts the retrograde approach as an equivalent to that is rather challenged in the literature. The other element of neuroprotection is also listed, namely hypothermia. The extent of hypothermia is also a matter of discussion. Deep hypothermia is more protective but results in extended procedures, coagulation disorders, and arrhythmias. Our group proposed the ultrasound-guided central cannulation of the lesser curvature utilizing the Seldinger method. This cannulation method facilitates the earliest cool-down, results in better cerebral and renal perfusion and whole-body reperfusion than the subclavian or femoral approach. On this slide, we can see the summary of the central cannulation benefits. As all perfusion access methods, this may require bailout approaches in a low incidence that is provided by other but different type of central cannulations. Here is the intraoperative view of the approach visible. The lesser curvature at the aortic ligament is histologically different in contrast to other aortic segments. It contains more connective tissue and the layers are more tagged, so the wall integrity is kept in most of the cases in type A aortic dissections. Another advantage is the prompt reestablishment of central true lumen flow, and the tip of the cannula is situated on the border of the distal arch and proximal descending aorta, leading to a reduced cerebral embolism possibility. These facts were reinforced by other aortic groups in the next decade after our initial publication, and experimental results consolidated the clinical findings additionally. Vada and colleagues have demonstrated good outcomes with their transapical aortic cannulation method that represents the choice of bailout for our method. Here we can see the intraoperative theory view of a transapical approach. On this slide, the samurai cannulation and the right upper pulmonary vein cannulation by the Keel group are displayed. Neuromonitoring of our patients was provided by near-infrared spectroscopy. Our preferred neuroprotection includes deep hypothermia in combination with selective antegrade cerebral perfusion. We aim to keep the brain tissue oxygenation close to preoperative values at 55–65%. We anticipate malperfusion if there is a constant drop more than 10% registered in contrast to preoperative values or the contralateral side. Although unilateral antegrade cerebral perfusion is well recommended in the literature, some challenges must be recognized in connection with the method. Unilateral antegrade cerebral perfusion doesn't provide sufficient left hemispheric perfusion in some of the patients, hence the circle of Phillips is incomplete in 17% of patients discovered by Merkler and colleagues. Unilateral antegrade cerebral perfusion leads to relative hyperperfusion of the right and relative hypoperfusion of the left hemisphere, even in a case of a complete circle of Willis. Computational fluid dynamics investigations also revealed the perfusion challenges posed by unilateral flow. Both in the table and on the video graph is visible that central cannulation provides more homogeneous blood supply to supraortic vessels and results in less turbulent flow in the ascending aorta and arch, in contrast to subclavian perfusion. Harkey and colleagues from Liverpool have demonstrated the advantages of central cannulation in comparison to femoral approach in their meta-analysis, and Malvindi and colleagues showed the advantages of selective antegrade cerebral perfusion during longer hypothermic circulatory arrest in contrast to the unilateral approach. Further cannulation methods are the brachiocephalic trunk approach by D'Auziano and the carotid cannulation by Urbanski that were mainly utilized in aneurysm surgery, but in some type A dissection cases were used as well. The reliability of body temperature measurement is paramount in aortic surgery applying hypothermic arrest. Misleading measurements may lead to devastating neurological injury or further complications. We have compared the reliability of tympanic, bladder, and rectal body temperature monitoring during deep hypothermic circulatory arrest and rewarming. The most reliable values to govern the temperature management of the patient is provided by the tympanic follow-up. The risk posed by inadequate rewarming is well investigated in the literature. We recommend the tympanic measurements to provide accurate neuroprotective values during both cooling and rewarming, but additional measurement points facilitate the follow-up of the homogeneous whole-body rewarming. Aortic valve resuspension and aortic root replacement recommendations are evident in the guideline. Root preservation is an option in well-selected young patients, although the procedural length is significantly increased by this addition. The recommended distal anastomosis management by the guideline is an open distal method in deep hypothermic circulatory arrest, although no further patient selection details are provided. This can be debated in elderly patients who have only a limited dissection on the ascending aorta. A new addition is the recommendation for frozen elephant trunk in selected patients. The frozen elephant trunk is a combination of a side-branched aortic arch interposition graft and an EVA, in contrast to the floppy classical elephant trunk. The EVA enables us to avoid a second-stage open procedure. The long-term outcomes are favorable in comparison to the classical approach. Patient age has a significant impact on the surgical approach of type A aortic dissections. We have investigated on the impact of age on both pathoanatomic features of type A aortic dissections and therapeutic consequences in a cohort of 235 patients in a series of 15 years. As we see, most of the patients are still in the 60-70 years of age range, but more octogenarians are operated on recently than 20 years ago. This table demonstrates the impact of age on pathoanatomic features of type A aortic dissections. Dissection entry in the aortic root, extension of dissection membrane over the ascending aorta, especially in the coronary sinuses or abdominal aorta, features the young patient population, and even with the exclusion of bicuspid aortic valves or connective tissue diseases, we get the similar picture. Similar trends can be observed on these graphs in age relation. The probability of proximal and distal extension of type A aortic dissections is inversely related to patient age. Regarding surgical procedures, in older patients, the isolated aortic valve replacement was the dominant at degenerated but not dissected aortic valves, and the aortic root procedures dominated the younger age. There was no significant difference in ascending or arch procedures between the two age groups. More frequent proximal and distal progression of the dissection flap occurs in younger patients with type A acute aortic dissections. Older age is associated with a lower probability of intimal tear at the level of the sinus of Valsalva. These findings, associated with prognostic implications, account for the choice of more radical proximal procedures for repair of aortic dissections in younger patients. In conclusion, the younger age suffering from type A aortic dissection is featured by more extensive disease, and more radical surgical approach is required in this group to achieve sufficient long-term results. Imaging follow-up is essential in these patients, and additionally, family member imaging and genetic screening should be considered at younger patients. Well-maintained blood pressure is a key for long-term medical management. Regular follow-ups can time reoperations adequately that are required in a significant proportion of patients after 10 years of the initial event. The importance of a well-organized aortic outpatient clinic is paramount. Thank you very much for the presentation opportunity and the kind attention.
Thanks, Dr. Gobelos. That was indeed a very detailed summary of the surgical management. Any comments from the panelists or the surgeons in the panel?
Yeah.
If not, maybe, yeah, Dr. Wu, please go ahead.
Yeah. Dr. Gobelos. And may I ask you a question that because we have very few experience on using the central aortic cannulation. So when you do that, you use the intraoperative epi-aortic echo to guide your cannulation, or you just cannulation at the laser curvature of the arch, just around that pulmonary artery area. Is that where you usually cannulate? You know, the bifurcation of left and right the pulmonary artery.
Yes, so what we are doing, first of all, we see the CT picture, so you can plan if that is a sufficient spot. Of course, there is a dynamic change possibility in the whole situation. We are following on TOE. On TOE, in most of the cases, you can see the guide wire quite well. If there is any doubt, then you can use epi-aortic scanning. In our hospital, luckily, we have the Medistim probe, so that's a definite epi-aortic scan. But if you don't have that, then you take a sector scan like pediatric surgeons do, and then you just put it into a sterile bag and you can scan the aorta itself. So you can choose the spot as well, and you see your guide wire. So it's really important to have a live feedback on what you do, because otherwise you can end up with nuisances. But I can tell you that originally, as it started, the Hannover group is doing the cannulation on different spot. They have done it as the usual cannulation spot, and they are cannulating through the dissection membrane, and they were not following up. Sometimes there is aortic rupture present with that kind of method. Their bailout is actually very similar to the proposed samurai cannulation. So Hannover has been doing it for a while as well, then transection and direct cannulation. So that's one of the bailouts. But I prefer to have controlled under ultrasound, and usually there is no nuisance present.
So when you do that, you still use the purse string to do?
No, you don't have to. You don't have to, because the purse string, first of all, it would be difficult to put there. Second, you have very strong tissues. And these Seldinger type cannulas are well sealed off just by inserting it itself. So you shouldn't put, because that increases also the possibility of rupture. And it will come out anyhow with the hemi-arch, that spot. So once you do the circurest, that spot will come out.
Yeah, so you actually, you resect that area that you
yes,
cannulate.
Yes. So the only fixation what we do, it's up at the jugulum. You fix the cannula to the skin and the soft tissues that it's not moving around, but that's usually enough.
So did you have a lot of oozing from the cannulation side that when you do that? No.
No.
Without the purse string?
No, because that's a minimally invasive cannula. It's well fitting and sliding in. Even I have some colleagues who are doing on the greater curvature, and they are not doing with purse string. If it is really needed, once the cannula is in, you can put around if you have a lot of bruising, but that's not very often.
Okay.
Thank you, Dr. Gopalos. Dr. Urawong, you have one last comment?
Okay, I may have question about the Dr.
Yes,
Ross about the how can you determine the ethic arch for the acute type A dissection? How can you approach for the arch, or how aggressive you perform the operation for the ethic arch?
or aortic arch. Aortic arch is as a standard, it is a hemi-arch. If you have any pathology there, you see a tear, then obviously you take out the whole arch. It's another consideration. Again, what we have from Abu Dhabi, we don't have this big aortic program. Previously, I've been working in England. There, at young patients, if the patient was having good general condition, then we have done Thoraflex, because of they were tolerating more longer procedure and they had the benefit long term. So in that case, then we have done the Thoraflex for those patients. And back to the topic as well, as I have presented with elderly patients, many times it's not hitting their aortic arch. Most of these patients just require an interposition graft of the ascending aorta. And I mentioned also in the presentation, although the guideline is suggesting that you do a circurest, we had many octogenarians. And if you need only a limited type, an ascending replacement, you can do it, many cases, only on clamp. You save a lot of time as well for the patient who are having comorbidities. And as I have mentioned as well in our study, what we have conducted in England, many of these patients don't require aortic valve or aortic root procedure. If they need something, mostly it's a degenerated valve, which will be a normal valve replacement.
Yeah, then if you in the all elderly, that you clamp and saw on the distal side, right? Is that what you're saying?
Yes.
Then in that case, is where you cannulate where did you cannulate with the central also, or you cannulate with the femoral and the axillary?
It's your choice. You can choose the femoral as well. I had some colleagues in England who are still preferring the femoral. Someone is going with the axillary. Someone will go with the central. So you will provide anyhow perfusion for the rest of the body. You are just working on the ascending aorta.
Thanks, everyone. I think the surgeons are getting very excited about the surgical techniques, but for the rest of the cardiologists and the audience, perhaps we're a bit lost. Maybe one question or feedback from Dr. Wu for the audience out there. What, in your observation, is the most common reason why the ED physician or cardiologist miss the diagnosis on presentation? What are the most common mimics for type A aortic dissection that you would like to tell our cardiologists out there?
You mean the misdiagnosis from the acute coronary syndrome?
Misdiagnosis for aortic dissection. What are the common scenarios that you've seen that people may have missed it?
Yeah, I think currently that because the widespread use of the CAT scan with the chest pain, in the emergency room, that actually have the chest pain specialist, not specialist, the chest pain center, and actually it's really rare to misdiagnose that with the acute aortic syndrome or type B aortic dissection with the so-called acute aortic syndrome. But the problem is that we still see some cases that misdiagnosis with the acute coronary syndrome between the aortic dissection and acute coronary syndrome. Is that because of the the EKG presentation? Because that the acute MI program that you really need to rush in the cath lab within 60 minutes to 90 minutes. With the so-called ST elevation myocardial infarction. So basically, in that short period of time, sometimes they misdiagnose the acute aortic type A dissection. But now it's less and less because of all you need to just put in a probe in the transthoracic cardiac echo, and you can really have a differentiate the acute type A aortic dissection with the acute coronary syndrome. with the transthoracic cardiac echo very simply in the emergency room that the early surveillance of this patient. Yeah, I think it's getting less and less with the widespread of the CAT scan. Yes.
Thanks, Dr. Wu. That's a very good teaching point. But just to state that it's not probably a misdiagnosis, it's a correct diagnosis of a complication of an aortic dissection, predominantly the RCA STEMI sometimes, and you're loaded with DAPT, sometimes with anticoagulation, and that makes it worse. So I think those scenarios are really bad for patients. So we're going to transit to Dr. Wu's talk now, switch away from type A now to type B management for acute and chronic aneurysms.
Yeah, thank you. So this is my. So can you see my slide now?
Yes, please go ahead.
Thank you for the organizing committee to give me the privilege to talk in the APSC call forum. I'm Dr. Yihui Wu. Today, my topic is contemporary management of acute or chronic type B aortic dissection aneurysm, except the Marfan syndrome, approach and the timing. Today, our outline for the day, we are going to talk about the type B aortic dissection natural history and the type B aortic dissection treatment algorithm, including the complicated versus uncomplicated. And in uncomplicated type B aortic dissection, we are going to talk about the best medical treatment versus best medical treatment plus TIVA. And what's the benefit versus the risk? And what's the effectiveness? And the when and the who will need to do the surgery. This is the trend in aortic dissection over the last 17 years. We can see that increasing percentage of the type A repair with fewer rejection from that surgery. And we can see also increasing endovascular management for type B aortic dissection and decreasing surgical repair for that. This is the outcome study of medical management of acute type B aortic dissection case back to 2006. So in this study, we can see that with the medical treatment of acute type B aortic dissection, the in-hospital mortality can reach up to 10.1%, and especially when intervention was required. This is the study from the Boston group describing the natural history of medical management acute type B aortic dissection from 1999 to 2010 with the 6-year follow-up of the 298 patients. We can see that the failure rate is about 58%, including the 119 cases deaths and 87 intervention, and 12.4% of the early failure, including the 14 deaths and the 25 intervention. And most of this complication came from the renal and the mesenteric ischemia. And in this study, we do see that rarely do complications occur during the 2nd week to 3 months interval. That's the subacute phases. In this study, at the 6-year follow-up, we can see that the patient had a 74.2% patient had a freedom from intervention, and 41% is intervention-free survival at 6-year follow-up. And the variable related to the medical failure is age over 70 and the end-stage renal disease. And this is the population-based assessment of the incidence of acute aortic syndrome. You can see that there is no difference between the 3 categories regarding to the survival. And we can see that compared to the normal population, the acute aortic syndrome cases had a significant worse survival curve along all the years follow-up, even excluding the early deaths. In the following years, you can see still poor survival compared to the normal. This is the survival over time in 4 different time periods. In the acute aortic syndrome, there's no really survival difference in this 4 time period from 1995 to 2015. And we can see that all the cases with acute aortic syndrome, most of the mortality occur in the 14 days and the 15 to 90 days, and also 1 to 2 years. In patient with type B aortic dissection, the best medical therapy really depends on the patient. adherence to the anti-hypertension medication. So in this study, we can see that up to 21% of patients with really low anti-hypertension medication adherence. And so the conclusion is that the medication adherence in patients with type B aortic dissection really needs improvement. So the IRA data shows that the natural cause for uncomplicated type B aortic dissection cases is 6 to 10% mortality within 30 days and 59% of aortic expansion within 2 years, and unknown risk for rupture and the death afterward. Most of the cases of acute type B aortic dissection mortality really occur within 40 days. So that's the so-called complicated cases, and most of them are attributed to the malperfusion and the rupture. So in the guideline, we can see that type B aortic dissection in complicated cases that really need the emergent TIVA or frozen elephant trunk if no option for adequate landing. In 2014 ESCC guideline, we can see that in uncomplicated type B aortic dissection, medical therapy should always be recommended as class 1 indication. For long-term follow-up in acute uncomplicated cases, we know that the progressive aortic growth is usually the issue. So in the subcategory acute uncomplicated cases, it raised the question that the early TIVA rather than best medical therapy can really benefit the long-term outcome in this patient. So in TIVA for uncomplicated type B aortic dissection, the benefit must outweigh the risk of repair and the effectiveness of endovascular repair. And the when and the who shall we treat the type B aortic dissection with intervention. This is the first randomized study comparing the type B aortic dissection with best medical treatment versus best medical treatment with TIVA cases, the INSTAY-XL trial. We can see that in the first 2 years, we don't see the difference between these two groups in regarding to the overall survival and the aorta-related survival curve. But after 2 years to 5 years, we can see that significant better survival can be found in patients treated with best medical treatment and the TIVA, and also the aorta-related survival is also significantly better in best medical treatment with TIVA. And this is all the composite endpoint. We can see that in the TIVA group, it also has significant better composite endpoints between these two groups. And this is the cause of the death since randomization. We can see that in the TIVA group, all of the deaths really occur within the 2 years. But with the best medical therapy, we can see that at following years, we can see that there was sequential mortality in the best medical treatment group. So in this study, we can see that TIVA for aortic dissection really prevent the late expansion and encourage aortic remodeling. So we can see up to 5 years, we can see in TIVA group, we have a 12.4% absolute rate reduction in the aorta-specific mortality and the 19.1% of absolute risk reduction in the disease progression. This late advantage is also supported by the MGH cohort study. We can see that TIVA for uncomplicated type B aortic dissection group had a better 6-year survival compared with the best medical treatment therapy. This is the study from JVS in patients with acute uncomplicated type B aortic dissection after TIVA procedure. We can see that the medical therapy had the lowest in-hospital mortality compared to the open repair and the TIVA, but after 1 year and the 5-year follow-up, the TIVA group has significantly better survival compared to medical therapy or open repair. So this is the guideline from the ESVS. It shows that to prevent aortic complication, uncomplicated acute type B aortic dissection, early TIVA may be considered selectively as a class 2B indication. So in type B LD dissection, there's really the so-called high-risk type B LD dissection and the low-risk type B LD dissection. This is the study analysis, the predictor for late LD intervention in patients with medical treated type B LD dissection. In this study, we see that 254 patients with medical management type B LD dissection. 12% patients require early intervention, and majority of the patients who require intervention were really in the late phase, and 100% were due to the annular growth. So this is the predictor. We can see that the entry tier more than 10 millimeter, the total aortic diameter more than 40 millimeter at presentation, and the false lumen diameter more than 20 millimeter, and the increasing total aortic diameter more than 5 millimeter between image study are really predictive of the late LD growth. And the thrombosis of the false lumen was really protected from the late LD growth. This is another study regarding the prevalence of risk factor predictor in patients with uncomplicated type B LD dissection. This is a retrospective two-center study between 2003 and 2016, and review of the CT scan of 65 patients enrolled, and to see the initial CT scan predictor related to the late LD growth. So this is the defined CT-based risk predictor of disease progression, with primary tier, entry tier more than 10 millimeter, primary tier location on the concavity of the thoracic aorta, and the total LD diameter more than 4 centimeter, and the false lumen diameter more than 22 millimeter, partial false lumen thrombosis, and the fusiform index more than 0.64. And we can see that the prevalence of predictor at the baseline CT angio, we can see that the most frequent comma was the more than 1 centimeter primary tier size. And the second is the partial false lumen thrombosis, and the following by the more than 40 millimeter descending LD diameter. So in this study, we can see that the more than 80% of the patient had at least 3 predictor, CT scan predictor for the late LD dilatation. And the average of CT predictor was 2. This is the correlation. We can see that with the more number of the predictor on the CT scan, the more progression to the LD growth in this patient. This is the linear regression analysis. So we can see that with per predictor increase, we can see that the LD growth is that 2.5 millimeter. So in summary, most of the patients with acute uncomplicated type B LD dissection had more than 2 morphological predictor to found to be predict the late LD growth. And actually the positive correlation of the number of predictor and the LD expansion was positive. So CT-based predictor really helped to define patients at risk for LD diameter expansion, and these are the potential cases for TIVA repair. So this is really the concept of a dissect classification system. It means that acute uncomplicated type B LD dissection cases really need to clarify the duration of the disease, the intima-tier location, the size of the dissected aorta, the segmental dissection area, and the extent of LD involvement, the clinical complication of the dissection, and the thrombus within the LD false lumen to categorization into the high risk or low risk acute uncomplicated type B LD dissection. This is the JAG review of the optical treatment of uncomplicated type B LD dissection. So we can see in uncomplicated cases, we really categorize the high risk feature on the initial CT scan. If it's really the high risk and with favorable TIVA anatomy, and really go to the TIVA procedure is beneficial. Then how about the timing? This is the study from the virtual register with midterm outcome and the LD remodeling after TIVA for acute, subacute, and the chronic LD dissection cases. We can see in this study, the window of plasticity for LD remodeling is open until 3 months. In this diagram, we can see that the subacute phases cases had the highest freedom from all-cause mortality in the follow-up. In this figure, we can see that the acute and the subacute cases has the same freedom from aortic reintervention and much better than the chronic cases. This is the true lumen area. We can see that the acute and the subacute phases had a better true lumen area gain in the 24 and the 36 months follow-up compared to the chronic group. So this is the false lumen area. We can see that in the acute and the subacute cases, in the early 6 months up to 36 months follow-up, had a significant reduction of false lumen area compared to the chronic group. So in conclusion, TIVA is able to provide good protection from LT-related deaths in the midterm, but with a high rate of LT reintervention in chronic cases. And the LT remodeling in subacute patients is similar to the acute group. The retention of aortic plasticity in the subacute group lengthens the therapeutic window for the treatment of uncomplicated type B LT dissection. This is the IRA temporal classification in the survival for type B LT dissection. We can see that within 7 days, the acute phases, we can see that a significant decrease on the survival in both endovascular and the medical management group. And in the subacute phases from 8 days to 30 days, we can see that really flatten of the curve of the endovascular and the medical treatment group. This is another study showing that the patient with subacute type B LT dissections had the lowest all-cause mortality and the ELTA-related mortality after the TIVA procedure. This is the current options and the recommendation from the EACTS. In uncomplicated type B LT dissection, after evaluation for these high-risk figures, including the size of the primary tear, the location of the primary tear, the total LT diameter, and the false lumen diameter, if really fit to the high-risk fitter, the TIVA is recommended within the 15 days to 90 days after the index event. So in conclusion, in the type B LT dissection, the nature history, all the complications in the acute phases most are from the malperfusion and the rupture. The complication in the subacute and the chronic cases, most of them are aortic dilatation. And the risk and the benefit analysis in the TIVA. High risk and the anatomical suitable patient in uncomplicated type B LT dissection should undergo TIVA procedure. And also the complicated type B LT dissection should undergo the TIVA procedure. As for the timing, the subacute phases is the most optimal timing for the TIVA because the subacute phases had the optimal therapeutic window opens when risk of the retrograde type A LT dissection was reduced and before the LT plasticity was lost. The LT plasticity can maintain up to 12 weeks, so if intervention is indicated, subacute phase is preferred. Thank you for your attention.
Thanks, Dr. Wu. That was a very, very clear lecture. I'll now like to call upon Jack Chung, if you have any comments or questions for Dr. Wu.
Hi, Dr. Wu. Jack Chung from Singapore General Hospital. I think the only controversial most of us have is the timing to act on it. is it 2 weeks for you, or is it 30 days to define the subacute phase? I think, what's your take on this?
Yeah, it really depends on the patient's presentation. Usually, for the uncomplicated type B aortic dissection, that means that you don't really, the patient didn't have the malperfusion or had a rupture on the initial presentation. Usually, you admit this patient with the anti-impulse therapy first, and then we scan the patient in about 1 week later, and we see that how that dissection progress. If you really see a rapid progressing within this just 1 or 2 weeks period, and then you may consider earlier, probably 14 days, to fix to do the TIVA procedure. But if you really think that the cascade is not really changing about the diameter, but you see the intima tear was really big, like a 1.5 centimeter. And all these patients, we will probably send back this patient in about 2 weeks admission. And then we will get another CAT scan in about 1 month, and to see that if there any change. If no, then we will admit this patient that about 1 month to 90 days to do the procedure. So it really depends. Usually, so basically that if the patient is not rupture, is not pale perfusion, so we will categorize this patient with the CT morphology predictor. And then we CAT scan this patient within 2 weeks admission. If the progression of the size of the aorta was noted, then we will do the TIVA, just maybe the same index per admission, but after 14 days. But if there's no progression or symptom worsening of this patient, we might get this patient back, within 3 months. But in between, we will do a 1 CAT scan before the procedure, and then we do the TIVA. So that's
Thanks.
probably our policy that doing the to treat these uncomplicated type B aortic dissection cases.
Thanks, Dr. Wu. Any other questions or comments for Dr. Wu's lecture? Dr. Wu Wong, please.
Yeah.
Thank you much, Dr. Wu.
Yeah, nice to see.
May I ask a little bit about your approach to the uncomplicated type B dissection? If your serial CAT scan show that it's stable, no symptom, what is your management?
Yeah, so it really, so what I'm saying that, so actually the high risk filter, including first the size of the intima tear and the diameter of the false lumen and the aortic diameter. But there's another one is called the progression size of the aortic diameter. Except the progression size of the diameter, you was noted in these 2 weeks, we really not hesitate at doing this TIVA procedure very quick. But in the initial CAT scan, you know that if the size of the primary tear is like a 1.5 centimeter, and the thin intima tear is really at a laser curvature concavity, or the size of the aorta is about a 4.5 centimeter. For this more stable, high-risk CT predictor, we still do the TIVA for this patient, but we will tend not to do it within 14 days. We will probably get, do this case at about 1 month to 3 months interval. Did you know what I'm talking? So maybe in this high-risk CT predictor, we still categorize which one is the highest and which one is the moderate high risk. That we should say that. So if you see the progression size of the, progressive increase of the size of the aortic diameter, we think it's the highest, the top dangerous high risk failure. So those cases we probably do it within the index admission. But if, as you say, we follow this patient, but there's no size change of the aorta, but the intima tear was about 1.5 centimeter. And this patient, we will do the TIVA procedure, probably after 1 month to between 1 month to 3 months, and we will get a CAT scan before the procedure.
Thanks. The same question sometimes that I get is, do you routinely also ask for a coronary angiogram or cardiac pre-op risk stratification for this group?
Interesting. No, you know, I'm not really a fan about doing the coronary angiogram before any the so-called elective ALD procedure. It's because I think I would think of this patient is symptomatic or non-symptomatic. If really symptomatic, or you can really see the Thalian scan is really positive and a strong positive, or really this patient had a history of a coronary stent or whatever, this patient probably may drive me more, you know, prompt to do the coronary angiogram. But as the type B ALD dissection, I almost rarely do this patient, send this patient to the coronary angiogram beforehand, because the TIVA procedure, basically it's an endovascular procedure. It's more like a coronary angio procedure, like it's all endovascular. It's not like an open surgical repair procedure. So I believe all this procedure, and actually we use all the heparinization for this patient during the whole procedure. So I think the risk of the acute coronary syndrome happening in this procedure perioperative is really, really low, because all this procedure is really, really catheter-based procedure. So I don't think that it really makes sense that to do any coronary intervention or angiography before the elective endovascular aortic repair procedure, unless it's really symptomatic. So not really, you know, I'm a big proponent to do all the coronary angio procedure before this elective endovascular procedure.
Thanks. I really like that answer as well. So, and I think you should just decide based on the clinical need.
Can I ask?
Yeah, go ahead, Jack.
Routinely put in a spinal drain for spinal cord ischemia for all these type B dissection that you stent?
Oh, you mean the spinal cord? Yeah, basically we not like open procedure. I think the spinal cord injury between the it's different between the open and the endovascular procedure. You can see that all the literature now that with the endovascular procedure, the chance of the spinal cord ischemia is really much lower than the open surgical procedure. So for me, that with the endovascular procedure, we don't really routinely put in the spinal drain before the procedure as the open that we did before. So even though I'm gonna cover the whole segment of the thoracic aorta, we don't really put in the spinal cord perfusion, not the spinal cord drainage tube beforehand, because we think that to preserve the left subclavian artery, to preserve the hypogastric artery, to make sure that you maintain the adequate systemic perfusion during the procedure is much more important than you putting the spinal drain to prevent the spinal cord ischemia. We only put in the spinal drain as a rescue procedure unless the patient really developed a spinal cord ischemia after the procedure. But in our experience, we don't see that in the regular regular TIVA procedure. We only see the spinal cord injury after the thoraco-abdominal endovascular repair. That means we do the T-branch, the branch devices to cover the thoracic, the abdominal aorta. Those cases that we do see some cases with spinal cord ischemia and require the so-called rescue spinal cord drainage therapy. But in the routine TIVA, we probably less than 1% patient developing the spinal cord ischemia. But remember, it's not zero risk to put in the spinal drain. Actually, in the literature, the complication rate from the spinal drain insertion actually really go to 2 to 3%. That means including the cecal, hemorrhage, and the headache, and whatever complication. It's about a 2 to 3%. So that means that if I had a lower chance than 2 to 3% of spinal cord ischemia, it really didn't risk me to put in the spinal drain before the procedure. And so that's why, because of especially in the TIVA procedure, we don't see that the regular TIVA procedure not the thoracoabdominal, like you put in the, you don't involve about the visual artery segment, then we rarely put in this, we don't, almost zero to put in the spinal cord drainage beforehand. But we need to really make sure that the subclavian artery is patent, the hypogastric artery flow is restored. You don't really obstruct the pelvic circulation during the operation, and you really keep the pressure up, like a systolic pressure more than 140 after you put in the TIVA, after you put in the TIVA. So really keep the hemodynamic stable and keep the hemoglobin about above 9, you don't really hypotense this patient. So I think these are more important than putting the spinal drain in this patient.
Thanks, Dr. Wu. That was a great answer. So in the interest of time, we're going to then transit, if there's no further questions, to session 2, which will also be chaired by Dr. Wu.
Yeah. Yeah, thank you, Jack. So I'm going to chair the next speaker, that Dr. Jack Chen. So Dr. Jack is So Dr. Jack is a senior consultant vascular surgeon at the Department of Vascular Surgery, Singapore General Hospital. So today he's going to talk about the survey and the prevention of acute or chronic aortic dissection aneurysm in the Marfan syndrome cases. So please go ahead, Jack.
Hi. Thanks for your kind invitations. Today my talk is going to be on survey and preventions of acute or chronic aortic dissection aneurysm in Marfan syndrome. Let's just start my talk with a simple case study that I just recently seen and operated on. It's a 33-year-old Chinese male with past medical history of Marfan syndrome, previous kyphoscoliosis with pectus carinatum and situs post-spinal instrumentations back in 1994, type B dissections, aortic root aneurysms, and mitral valve regurgitations, situs post AVR mechanical valve Bentall procedure with MV repair back in 2000. She also had a left thoracotomy reconstruction of the aorta and insertion of the 24 mm Dacron graft back in 2003, and also aortic arch replacement with tri-branch Dacron graft mitral valve replacement back in 2013. Multiple operations since then, and on regular follow-up with us. In 2020, his latest CT aortogram shows a residual aortic dissection in the descending thoracic aorta extending into the abdominal aorta. The fourth lumen is patent, and there is aneurysmal dilatations of the descending thoracic aorta and abdominal aorta measuring 6.9 times 6.7 centimeter. So this is just a CT scans, just a pre-op CT scans showing the large fourth lumen is still patent, and the most of the visceral artery actually comes out from the true lumens, except one of the renal arteries. So this is another view showing the thoracoabdominal aneurysm involving 4 visceral arteries. Extensive discussions has since then discussed with the patients and family open versus endovascular repair. Obviously, the durability of the endovascular repair has been stressed to the patients, and also the doubt of a radial force of the stent graft, and also patients' factors are all taken into considerations before patients subsequently agreed to go for a endovascular procedure. He subsequently underwent a custom-made device with 4 vessels fenestrations, and I think the key to take home for endovascular procedure for these Marfan patients, we need to exclude stent graft with bare stents and bulbs at the top, and also the proximal landing zone in a pre-existing graft. We must land our new graft in the old graft, and in this patient's previous open thoracic aneurysm repair. The next point to take note is to minimize the proximal oversizing when landing in proximal native aorta. If you are not landing in a previous stent graft, and the distal zone, we must always undersizing for chronic dissection cases. Okay, so back to our topic after the case study, survey and preventions of acute or chronic aortic dissection aneurysm in Marfan syndrome. Why do we need to survey them? Because way before that, this was an article published back in 1972 in New England Journal of Medicine. The lifespan of untreated patients with Marfan syndrome, they classically die at the age of 32 years old back in 1972. And the main cause of death at that time is all aortic, related to aortic dilatations and its complications, as you can clearly see here. And why do we survey? Because the prognosis has improved since then with survey, and the average survival has increased to 72 years old in 1993. So why is there improved in survival? First of all, use of medical therapy, beta blockers, and angiotensin receptor blockers. What do we use for Marfan syndromes with aortic aneurysm? Beta blocker is the first line, followed by angiotensin 2 receptor blockers. To the lowest level, patients can tolerate without side effect. The long-acting beta blocker is preferred because it improves the compliance. Atenolol 0.5 milligram per kilogram per day is used. If not, losartan is an alternative or adjuncts to beta blocker. And the second point to take home is how to improve survival, we need routine non-invasive monitoring of the aortic size. And this chart shows that the age at the first presentations of Stanford type A dissection in Marfan's patients, men actually experience aortic event at much younger age than women, and they actually experience the first dissection at the age of 20 to 30 years old. How do we monitor aortic monitoring? Echo should be performed at the time of diagnosis and 6 months later to determine the aortic root, ascending aorta diameter, and the rate of enlargement. CT and MRI also needed at the time of initial evaluations to confirm the echo findings and to confirm the echo measurements, and also to identify the aortic and vascular disease that is not appreciated by echo. So what are the limitations based upon absolute aortic root diameter? Predicted aortic root diameter may vary with body size, age, and smaller in women. 15% of patients with Marfan actually have dissection at the diameter less than 5 centimeter, and hence some of the people are actually using aortic root ratio rather than the real size. So what is the aortic root ratio? Aortic root ratio is a ratio between the observed aortic root diameter and the maximum predicted aortic root diameter as calculated according to the age and also body surface area. So if aortic root ratio is more than or equals to 1.3, that's an indication for surgery. So how do we measure aortic diameter at the sinuses of Wasava? Is a key measurement since this is a segment that generally dilate initially, and annual imaging for aortic dimension of less than 45 millimeter, for aortic dimension of more than 45 millimeter or shows consistency of growing over time, probably scan them twice a year. The aortic diameter measurements technique applied to follow a given patient should be noted and used consistently in the same institute. If you are following up with an echo, use echo all the time. If you're following up with a CT scans, make sure you use the same modality all the time and compare year to year. Within a nomogram, also specific for the technique applied when determine deviations from the appropriate age and size match normal population, what we call a Z-score. So this is just a chart showing different aortic diameter according to body surface area as well as sex. This is for women. And lastly, how do we improve the survival? Elective surgery repair of the aorta. Aortic root replacement, elective replacement is preferable to emergency repair. 30 days mortality for elective repair as compared to urgent repair within 7 days after surgical consult, or emergency repair was 1.5, 2.6, 11.7. And in this series, 46% of adults with aortic dissection had aortic root of less than 65 millimeter. So elective root replacement survival at 5, 10, and 20 years was 88, 81, and 75%. What are the indications for surgery according to the ACCA, HA, and AATS guidelines? External diameter of more than 5 centimeter to avoid acute dissection or rupture. Less than 5 centimeter if there's a rapid growth of more than 5 millimeter per year. Family history of aortic dissection at diameter less than 5 centimeter. Presence of aortic valve regurgitations, and planned cardiac surgery for another reasons like a mitral valve replacement, or patient considering pregnancies, or in symptomatic patients. In children's, optimal timing are really uncertain. Need of adjustment for body size. Of note that their size may be different. And in children younger than the age of 12, dissection is rare, irrespective of aortic dissection. Indications for surgery are almost similar to adult: rapid enlargement of more than 1 cm per year, or progressive aortic insufficiency. So lastly, to improve survival, of course, we have to counsel the patients with restrictions to vigorous physical exercise. So recreation exercise, low to moderate intensity, approximate 4 to 6 metabolic equivalent can be recommended. Non-competitive exercise such as brisk walking, stationary bike, golf, modest hiking, or double tennis are recommended. And no contact sports, of course, or exercise to exertion or isometric exercise are restricted. So in conclusion, to improve the survival in this particular subgroup of patients, use of medical therapy, beta blockers, and angiotensin receptor blockers, routine non-invasive monitoring of aortic size, and when they hit the indications for surgery, elective surgery is much preferred than emergency surgery and have a better survival. Restriction of rigorous physical exercise. Thank you.
Thank you, Jack. It's an interesting talk on the Marfan syndrome patient. So one quick question that for you on the last conclusion, you say that not vigorous exercise for this patient. Actually, this patient are really young at the 10 to 20, and how did you do the recommendation to this patient?
Well, compliance is always an issue for them, especially. I suppose you have to have a good family supports and with their families and parents around to counsel them. And actually, the truth is, those that's a bit more complicated. They do get multiple operations even at a very young age. And to be honest, physiological age, they are very old compared to their real age. So they themselves are not very active, to be honest, at a young age because of multiple surgery. As you can see, the previous patients that I just showed at 34 years old, he had probably went through like at least 10 surgeries, and he had multiple contractures even in between joints. So to be honest, they are, some of them are not really that active, and for those that active one usually had rarely had any aortic complications.
Yeah, that's interesting because of except weightlifting. Actually, I told my patient that actually they can still do anything they want because of you've really restrict the life, the regular exercise things that for them it's really difficult because these are really the young age patients. So how about this for the panelists like Followup and Dr. Followup and Dr. Gobles? How do you recommend it on your patient about the routine, regular base of daily life, the exercise? So we start from Followup.
Yep. For the young patient after aortic surgery, I recommend him he can do jogging, he can swimming, but not recommend to do weightlifting also, and the strenuous exercise, not to do that.
And how about Dr. Gobles?
Very similar. So bicycling, swimming, walking, hiking, jogging, it's okay. No weightlifting, no contact sports, so no sumo.
No sumo. So how about Professor Takeda?
Okay, I'm similar. Just swimming and light jogging is better. Yeah.
Yeah. How about Professor Ra?
Just avoiding too much strenuous activity, just the usual activity will be fine.
So actually, the other question I want to ask is that how many % of your patient really can be on the so-called losartan therapy for this connective tissue disease patient? Because in my experience, all these patients are really hypotensive, actually. They don't really need the medication for any anti-hypertension medication. So for me, that it really giving the very, very low dose of the losartan therapy on this patient. So what's your experience on that? Let's start from Professor Ra. So how do you give this prescription to your patient with connective tissue disease?
Actually, in Korea, we have done a multi-center study with low-dose losartan versus low-dose ACE inhibitor, but we found no difference and no specific benefit from the systemic impact of this low dose medical therapy. So actually, I'm not so clear with this kind of our so-called best medical or the optimal medical therapy for this particular group of patients. So mechanical intervention or surgical help or the regular physical rehabilitation or any other supportive measure other than the usual medical therapy, still we need more large N number study will be required to establish some more theoretical or data-based practice.
Yeah, thank you. So how about Professor Takeda?
Yeah, we usually use the losartan at dose of 15 to 75 milligram. Most cases okay, but sometimes they have hypertension. So in that case, we switch to the beta blockers.
What about Dr. Goblos?
Sorry, I just had to switch back the microphone on. We are trying to titrate, and so long the patient is tolerating, then we have to lower his dosage. So that was our strategy.
How about one-on-one? How did you give both the beta blocker and the losartan together with the patient?
We start with the beta blocker first, and if they can tolerate, we start the losartan later.
Okay, Jack, how about you?
Yeah, mostly just beta blockers. As you say, compliance is a key issue. At their young age, they usually don't take medicine very well.
Yeah, that's also my issue, that even low dose beta blocker, they don't really tolerate, actually, honestly. Okay, so that's the last question is that how about the root repair? So in your slide, Jack, that you say that actually the LD root replacement is sometimes required in this patient with the indicated. So how about the root repair? And what's your threshold for the root repair, LD root repair in this patient? Because in our experience that if the patient really developed the aortic insufficiency, like to moderate to severe, it's really in our hands, it's really difficult to fix them, this patient with the root repair, like a David procedure in this patient, because we really cannot fix the leakage of this valve. So what's your threshold to do the root repair in this young connective tissue disease patient?
I think I'm probably not the best person to comment on this because I'm a vascular surgeon, but I think like what you say, it's difficult sometimes. In my center, I see a lot of them. They just go for Bantal most of the time because it's just difficult to deal with, especially with so much connective tissue. It's just difficult to preserve the valves.
Yeah.
What are the others' experience?
Yeah. How about one-on-one? How about in your hands?
I've preserved the root if I preserve the valve if we have the perfect valve. If not, I think we have a lower threshold than other patients.
How about Goblos, Dr. Goblos?
Same here. So you have to have a good material to have a good repair. If you don't have it, then you have to replace it. Then it's a Bantal procedure.
Yeah. Then how about Takeda, Dr. Takeda, Professor?
Yeah. I'm sorry. I'm a physician, so but most cases under the mild aortic insufficiency. So most cases are performed by a David's procedure in our institute.
Okay. Then how about Professor Rao? Or in your center, you see them with the moderate or severe ALD in regurgitation, they replace the valve with they do the LD root replacement or LD root repair procedure.
Just most of them are followed by the cardiac surgeon. So really, our cardiology department or the vascular surgeon have limited experience in the long-term follow-up. So generally, I don't think that really the patient number is also very not many in our hospital. I think the Korean population. How about in Japan? Similar in East Asia. These days, we really don't see many patients of this Marfan. So very limited experience in my personal setting.
Yeah.
Japan, you have
Takeda, yeah.
Mm-hmm. Yeah.
Any number in Japan?
Mm-hmm. Yeah. Actually, we have the center of the Marfan syndrome. So we have many Marfan patients. So that population is not so different from Western countries.
Interesting. Yeah. Okay. So thank you, Jack. So we are going to proceed to the next speaker, Professor Takeda, and who is the University of the Tokyo Hospital, Tokyo in Japan. And you are going to talk about the contemporary management of acute or chronic aortic dissection aneurysm in Marfan syndrome, approaching the timing.
Okay, thank you very much. Can you see my slide?
Yes.
Okay. Thank you, Chairperson. It's a great honor to be able to present here to discuss it. This shows a representative natural history of Marfan syndrome. In the childhood, ocular and the skeletal and pulmonary abnormalities are more likely to be the problems. However, the aortic root aneurysm is also growing from the childhood, and serious aortic events occur mainly in the 20s, 30s, and 40s. Surgical replacement of the aorta is recommended when the aortic root diameter is over 45 to 50 millimeters. However, it remains difficult to precisely predict when and how fast aneurysm grows to the size at which surgery is indicated. This results in the substantial anxiety for young patients and their parents. In 2020, JCS, a Japanese Psychiatric Society, and related societies revised the guidelines for the diagnosis and treatment of aortic aneurysm and aortic dissection for the first time in the 10 years. These guidelines had not been translated in English, but today I am a physician, so I will present a summary on this, the management of the aortopathy in Marfan syndrome, as well as the role of the genetic tests in this field. Here is a description about the medical treatment. I will skip this one, but Dr. Jack presented the effect. ARBs are permitted as an alternative to beta blockers. Here is a description about the surgical treatment. Some parts are extracted here. Blue parts are class 2A in the previous guidelines, but in the revised guidelines, these were classified as class 2B. The revised guidelines raised the threshold diameter for aortic surgery by 5 millimeters. A class 1 threshold diameter for the aortic surgery raised from 45 to 50 millimeters. Also, in the case of patients with risk factors for aortic dissection, such as family history of dissection, a class 2A diameter raised from 40 to 55 millimeters. Here is the supportive evidence published in 2012. They examined 732 Marfan patients without having previous aortic surgery or dissections and found the risk of death over the dissection was below 0.3% at diameters at 45 to 49 millimeters, but the risk increased 4 times at the diameters over 50 millimeters. Next, this is a part concerning the pregnancy, which remains unchanged. We should consider aortic root replacement in women contemplating the pregnancy when aortic ascending or the aortic root diameter exceeds 40 millimeters in Marfan syndrome. A risk of dissection is pregnant parents, patients with Marfan syndrome is summarized here. The overall risk of pregnancy-related aortic dissection in Marfan syndrome is 3%, and aortic size is a major determinant of the risk. Here is the supporting evidence from Japan for the 40 millimeters. This is follow-up data about sub diameters during the pregnancy of 21 women. 7 patients colored in red developed additional aortic dilatation or dissections during pregnancy or within 1 year after pregnancy. And 6 of them had aortic aneurysm over 40 millimeters before pregnancies. Accordingly, we recommend the prophylactic surgery at over 40 millimeters in women. Next, in the revised guidelines, the statement of concerning the Lois's syndrome is added. In Lois's syndrome, we should consider aortic root replacement at smaller aortic ascending or root diameter than Marfan syndrome. As you may know, Lois's syndrome is a Marfan-like syndrome caused by the pathogenic variants of the TGF-beta signal-related genes. Lois's syndrome patients have a triad of the clinical features like this: hypertelonism, split uvula, and arterial tortuosity and aneurysm, especially in the craniocervical regions here. Lois's syndrome patients were classified according to the mutated genes. Lois's 1, 2, 3 are caused by the TGF-1, R2, and SMAD3. Have been reported to be associated with early onset and aggressive thoracic disease. In this guidelines, 2014, aortic root replacement is recommended when aortic root diameter exceeds 40 millimeters. Well, in this way, in clinical practice for hereditary aortopathies, we cardiologists are often required to have sufficient knowledge regarding to the genetics for providing the best clinical management. In 2018, the Clinician Aortopathy Expert Panel have classified 11 causative genes as category A genes. Genetic tests for these genes are recommended to perform for the management of patients and their family members. In Japan, the genetic tests to guide precision medicine have been covered by health insurance since 2016. For young patients and their parents having substantial anxiety for a long time, identification of causative genes and genotypes may provide useful information on when and how fast aneurysm grows to the size at which surgery is indicated. We consider these approaches and measures are important for the management of Marfan syndrome and related disorders. Here, let me present our previous paper on the fibril-1 genotype and aortic phenotype relationship in Marfan syndrome. The goal was better define which types of variants result in the increased progression of aortic disease. We enrolled 248 patients who had pathogenic fibril-1 variants. Haploinsufficiency or HI variants were defined as nonsense frame shift or out of frame exon skipping. Dominant negative variants or DNA variants were defined as nonsense in frame, missense in frame indel, in frame exon skipping variants. When stratified into the subgroups by types of fibril-1 variants and sex, multivariate analysis showed that the HI carriers had 2.5 increased risk compared to the D-end variant carriers. And also male patients had 2.5 increased risk compared to the female patients. Our results were consistent with previous reports, that is, HI variants result in more aortic phenotypes than D-end variants, and aortic root dilatation is more common in men than in women. Next, we sought to define a subgroup within the D-end variant carriers who had higher risk of aortic events. Among 7 DN variant carriers who had severe aortic events at less than 20 years of age. In other words, these DN patients had unusual severe aortic phenotypes. 6 had variants affecting conserved cysteine residues within the tandem array of CB-EGF domains in the middle of the genes. Accordingly, we defined any such variants as DN-CD variants. When we stratified the entire cohort by Fibrilary 1 variant type, now with 3 categories, HI, DN-CD, and DS non-CD, we found a multivariative analysis that DN-CD variants carriers had 6-fold increase compared with DN non-CD variant carriers. And also the HI variant carriers had 3-fold increased risk compared to the DN non-CD variant carriers. Today, I will skip the several other data, but here is a summary. Regarding to the Loitis syndrome, recently being recognized to have a wide spectrum, and survival of patients with Loitis 1 and Loitis 2 is considered much better than initially reported. MSc International Aortic Consortium revealed the characteristics of high-risk patients like this. TGF-beta male had greater aortic risk than females, whereas the TGF-beta 2 males and females had similar aortic risk. Presence of the TGF-beta R2 mutation, female sex, and aortic tortuosity, extra aortic features is associated with the increased aortic dissections. Recently, the copy number variations has also been recognized as important for genetic analysis. Copy number variation, or CNV, is usually defined as the genetic duplications or the deletions greater than 1 kilobase in size. CNV is linked to the dozens of human diseases. However, unfortunately, CNV is not normally examined by routine NGS sequence analysis. And automatic CNV prediction tools still suffer from the high proportion of false positive predictions. So we analyze the NGS data, next generation sequence data from 84 unrelated patients diagnosed or suspected of syndromic aortopathies. Pathogenic or likely pathogenic single nucleotide variants or short indels were identified 69 patients. Then we simply predicted CNVs by a visual review of the depth of coverage patterns using the integrated genomics viewer data server. This is a representative result of CNV screening obtained from the patient clinically diagnosed with Marfan syndrome. Horizontal axis represents the genomic positions, and each box shows one exon. A vertical axis represents the read depth. That is the number of times that a given nucleotide has been read in an experiment. As you can see, compared to the control, this patient had approximately 0.5 of the read depth between the exon 51 to 63 here. This strongly suggests the presence of heterogeneous multi-exon deletions in these regions. To confirm the genetic alterations and identify the breakpoint locations, we conducted RACGH analysis and identified a total 7 CNVs from the 84 patients with syndromic aortopathies. This is a summary slide. We were able to identify the 7 exonic CNVs in 84 patients with syndromic aortopathies, which account for the 47 of the causative variants in 15 patients having no pathogenic variants in routine NGS sequence. We think the incidence rate of CNV might be more than previously reported if Lucci sequencing is negative in such patients. A CNV analysis should be incorporated into the clinical diagnostic cares. At the last part, I will talk about the statement regarding to the surgical treatment. As I mentioned earlier, class 1 threshold diameter for the aortic surgery raised from 45 to 50 millimeters. Aortic valve sparing operations have become the preferred surgical procedure also in Marfan syndrome. Dr. David reported the long-term result like this. Aortic valve sparing operations in Marfan syndrome were associated with low rates of valve-related complications in long-term follow-up. Aortic insufficiency, or AI, greater than mild at 15 years was 77.9%, lower after reimplantation techniques than the remodeling procedures here. At type A aortic dissection, extent of the initial surgery is reported to determine the need for reoperations. This shows the freedom from the need for aortic root reoperations in Marfan syndrome with type A dissections. All patients underwent ascending aortic replacement. The greater need for aortic root reoperation on this group, having only supracoronary ascending replacement compared to this group having composite valve graft or the valve sparing operation. This indicated that the aortic root replacement or repair is highly recommended in Marfan syndrome with type A dissections. However, of course, this is a high-risk surgery, so therefore the operative procedure depends on the situations. This shows the freedom from the need for aortic arch reoperation from the same cohort. About 20% patients with hemi-arch replacement required secondary arch reoperations. And so in Marfan patients with type A dissections, a total arch replacement is also preferred if the situation allows. At the last part, I will talk about the endovascular treatment for the hereditary aortopathies. The revised guidelines declare that aortic surgery through a left thoracotomy is more recommended than TIVA if the region is located at the descending thoracic or the thoracoabdominal aorta in Marfan syndrome. Because this is because of serious and complicated device-related complications in Marfan syndrome. However, we can consider a TIVA or EVA procedure in these situations as bailout procedures or bridge to the definitive open surgeries, or as a procedure following prior aortic repair when both landing zones lie within the previously cited prosthetic grafts. This is conclusion. I apologize for my taking time. At first, I'd like to acknowledge all my collaborators at the University of Tokyo Hospital. Thank you for your kind attention.
Thank you, Professor Takeda, for your. I think most of your work is on the basic genetic study in this patient. So, one kind of cognitive disease that you didn't mention too much is the Ehlers-Danlos syndrome. I think in our experience that we had the most frequent met was the first is the Marfan syndrome, definitely is the most frequent patient that we see. And the second is the familial thoracic aortic aneurysm, that's the second one. And actually we rarely see the Lois Dice patient or patients, but we do see some Ehlers-Danlos. Especially in some Ehlers-Danlos patient, we see some coronary artery aneurysm change in this patient. So what do you recommend? Because in Marfan, we rarely see the coronary artery aneurysm, and in the familial thoracic aortic aneurysm, we rarely see the coronary artery aneurysm. But in elderly, we do see the coronary artery aneurysm. So did you have any recommendation on that?
Actually, we haven't checked the coronary artery in normal Marfan patients. If not, of course, when we do the we undergo the surgery, we have checked the aortic around the aortic valve, including the aortic coronary. Maybe most cases were performed by the coronary CT now, but I haven't seen the coronary problems in Marfan syndrome. Also in Rostis syndrome, I haven't seen such, but in Rostis syndrome is maybe about 10% of the Marfan-like syndrome. I think you should about 10%, but most patients, about 70% have any of the triad. So maybe now we can easily find the Rostis patients. Yeah.
Yes, we don't see coronary artery aneurysm often either. But what I say is that ehlers-Danlos. That did you see? Because in your talk that you don't talk too much on the ehlers-Danlos syndrome. So what's your experience on that? Did you?
No, actually no. We have
ehlers-Danlos. No. Okay. So how about Professor Ra? Did you have experience about the connective tissue disease patient that with coronary artery aneurysm cases that, and if that, how did you treat that?
I have most the Kawasaki related coronary disease, not like this Marfan ehlers-Danlos. So no particular comment for this.
Okay. So how about Professor Warawang or Dr. Goblos? Now we start from Warawang. Did you see any coronary artery aneurysm?
We didn't see, no.
Okay. So how about Goblos? You see? No.
Not much.
Yeah, because I ever had one patient with ehlers-Danlos. He has the root aneurysm, coronary artery aneurysm, like almost 4 centimeter. And also the AAA and the thoracic aneurysm. But that case was ehlers-Danlos, so that's what I'm asking. Yeah. So Professor Takeda, so what do you mean the copy number variance that because I'm not really a genetic specialist. So what that means that does that mean that even you had the same mutation, but if you had a different copy number, so does that gonna reflect on the the phenotype of this patient or not?
Okay. Actually, patient with CNV mutations have very typical Marfan syndrome features. So we don't, but very similar to the normal Marfan syndrome. However, even so, the NGS analysis do not detect the CNV abnormalities actually. So patient and their parents have a very tremendous anxiety for the future. So we need to now we will need to check it. Yeah.
Okay. So Warawang, you have a question? Oh, you are muted. Can you dismute it?
Okay. May I ask Professor Takeda that do you study the genetic in the patient, the young dissection patient in every patient? The young patient?
Yeah, actually, genetic test is performed by the health insurance, but still the out-of-pocket cost is still expensive, about $220 US. So about 50% have the genetic test in our institute. Of course, just for the diagnosis, this is not necessary, but genetic tests provide tremendous information, the future perspective. So, yeah.
Yeah, any further questions for Professor Takeda? Okay, if no, then we are going to proceed to the Professor Rao, who is the Professor, Department of Cardiology, Internal Medicine, College of Medicine and the Korea University, is the Director of the CAS Lab, Cardiac CAS Lab, and the Vascular Intervention Clinic. So he's going to talk about the contemporary management of the abdominal aortic aneurysm, the approach and the timing for us. Thank you.
Okay, thank you for your kind introduction. Can you hear me? This will be the last talk in this session, correct?
Yes, this is the last, yes.
Can you see the slide?
Yes, we can see, yes.
Okay. Can you see? Oh.
Yes, we can see it.
Including you have 2 minutes because you need to share your presentation.
Move to.
Yeah, you are using the speaker mode, not the displays mode yet, I think. So maybe the right lower button, yes. Yeah, here you see, yes. Yeah, maybe click on that.
Can you see, or just to? So left to right is different. How can reverse this?
Yeah. So maybe the right lower button that you see the gray. Yeah. A little bit right. Yeah. Here you go. Here should be the display mode, right?
Yes, display, but the display is shown in right.
Yeah. So I don't know what's going on, but usually that's the mode that we use. Is there any technical support online that? Or yeah, you go. Yes.
How about this?
If you go on the top, there are 3 options on the top.
Yes.
Oh yeah, here we go. Yes, here you go.
Perfect. Now it's perfect.
Yes.
Can you see? Or...
Yeah, we can see. Yeah, you can just go back to the previous. I know you probably have 2 screens, right?
Yes, 2 screens.
Yeah, so that's why you have to change the other one. Yeah, then let's go. Yeah.
Can you see?
Yeah, we can see now. That's perfect now.
Okay. Can I start?
Yes, please.
Okay. This is what I asked from the organizer. Because the title is too broad, then I emailed to the Dr. Rin. She replied, please try to summarize for the focus on the early detection and decision on the timing of elective or emergence surgical endovascular intervention or the post-intervention care. So that's why I made this content, early detection of trip-ray and the decision of timing of a trip-ray intervention and the post-intervention care, including endoleak management. But those are the content from the organizer. So the trip-ray detection is mainly self-detection by the patient, feeling of a self-pulsating mass or the routine physical examination from the private clinic or the routine checkup or the routine checkup by the abdominal sono, including some imaging study from the regular checkup. That is routine story without the symptom. However, the physical examination from the clinic, I was thinking how many percent of physical examination can be successful. Do you know this? I was curious, so I tried to find out from the literature that only less than 40% patients with the huge trip-ray, even the manageable trip-ray could be detected by physical examination. So our hand are not believable, are not can be reliable to detect the really pathologic aneurysm. And especially the obese patients, only 15% of trip-ray can be detected by physician. So we have to rely on the screen by the imaging. So US guideline or the ACC/AH guideline, these are the traditional, the usual guideline recommendation, especially smoking history. The elderly than 65 years men are recommended annual surveillance by the ultrasound. And the little younger men, 60 years or older, however, with the history of the trip-ray, offspring or siblings, little more younger men should receive the annual checkup. These are the screening recommendation. Same story, 60 or elderly with the ever smoked patients, and the younger, a little more younger, over 60 years with the siblings or offspring. And these depends on the size, less than 4 centimeter every 2 to 3 years ultrasound, and between 4 to less than 4.5 centimeter every 6 to 12 months ultrasound or CT scan is recommended for the surveillance to decide the management. And the repair, definitely over 5.5 centimeter dimension by the CT scan should be treated. And can be beneficial between 5.0 to 5.4 centimeter. And over 4.5 should be treated. So how about the small intermediate size? The guideline, US guideline, they recommend this kind of follow-up schedule, 6 to 12 months in the intermediate size, lower than 4.0 centimeter, 2 to 3 years. And while during follow-up, medical therapy is strongly recommended for the stop smoking and the risk factor control, including hypertension. Traditional, the risk factor reduction will be related to the risk and less mortality and morbidity. And the beta blocker, in our country, small trip-ray multi-center study with the diverse of medical therapy, RAS inhibitor, beta blocker. We have done some studies, but the risk reduction was similar to the medical therapy. The BP control was more important than the different medicine. Antibiotic therapy and some infectious cause will be helpful. Screening for the aortic aneurysm, in different recommendation, but the content must be similar, age-wisely and size-wisely. But this USPSTF recommendation, there is a risk assessment for risk factors, elderly population, smoking, first-degree relative with AAA, and the coronary artery disease, CV disease, and atherosclerosis, hyperlipidemia, and obesity, hypertension, they recommended. And the reduced risk included African American, Hispanic ethnicity, and the diabetes. There's some known literature. And the Vascular Surgery Society in 2017, they also recommend the imaging surveillance, ultrasound or CT, and the ultrasound screening, same as the ACCH recommendation, the smoking history with the elder than 65 years old, they should annual ultrasound screening. And the relatives or the siblings of AAA, little younger, should also. Man or woman elder than 75 years with the tobacco history should screen. And this is a little more less wider interval screening will be recommended in this different size. 2.5 less than 3 centimeter, 10-year ultrasound screening, and 3-year interval for the 3 to 3.9 centimeter size, and the 1-year interval for between 4 to 5 centimeter, and 6 months interval between 5 to 4.4 centimeter. So these are the usual recommendation surveillance schedule. However, when we look at the real-world practice, most of the treated patients, we should consider all the guideline expanded criteria to real-world treated patients. So it means that many cases we are actively screen the patients. So not only the men, women also, the more the recent date, more women patients are screened actively and treated more less criteria, even more than 5.0 centimeter elective abdomen aneurysm can be treated. This is what I mentioned, one series of group coronary disease patients, over 2,700 patients, 270 patients. All the coronary patients underwent surveillance for the AAA. The prevalence was 1.1%. High risk of CAD patients, undiagnosed AAA was 1.7%. So obesity was a common factor for AAA in these patients. So undiagnosed AAA, significant CAD must be a little more higher percent of usual control patients. So when we consider this AAA screening and surveillance, we have to think of a specific cause, including trauma, infection, and inflammatory disease, and connective disease. And most AAA are non-specific. However, some risk factors of patients are included, including smoking and male sex and family history, and ASCVD and hypertension, and previous coronary disease and the CVA. We have to think of more active screening. So my screening criteria in my outpatient clinic, I'm thinking more, the more the risk factors combination, I'm thinking of especially family history of AAA and with multiple risk factors. I'm trying to screen more actively. However, in Korean society, actually many are coming from the nearby private clinic, and they are nationwide annual screening program for the health checkup. So annual health checkup, they including the abdominal sonography and the patient intention to 2D echography annually. So these are routine automatic checkup for the abdominal aorta together. So self-detection and this nationwide checkup for the aorta, usually they sending patient to me. So, and also in hospital multi-department referral, especially the cardiac surgeon and vascular surgeon, when indicated for the graft intervention, they are sending to me. So other also department, also my outpatient self-screening program, these are the earlier detection program of myself. The second issue is a decision of timing of the when to the triple intervention. So anatomic consideration is usually my consideration for the EVA versus surgery. So triple location, especially the because we can do something for the snorkeling or the branching device or anything complex puzzle we can do, but long-term durability and the physiologic situation. So I'm trying to decide, especially hostile leg, to prevent the Taiwan and long-term better outcome. Sometimes in particular case, we try to decide the long-term better prognosis for surgical selection. So anatomy consideration is also important, not to only push it toward the endovascular intervention. The size is really matter. This is not actually a matter for the surgery versus intervention, but only the timing of intervention. The larger the size, is better to, because the rupture risk will be increased. So increased rupture risk definitely depend on the diameter increase. Rupture risk, annual risk will be increased with a greater percent. So this is well known, the larger the risk factor. And the rupture risk, we can classify into low risk to the higher risk. As you can see, the larger the risk, diameter and the expansion rate, and the smoking and the COPD presence with the steroid therapy will be the addition of the higher risk, and the family history and poorly controlled hypertension. So it means that we have to control the patient with reversible factor with intensive medical therapy. When patients are not tolerable, the condition is not good for the immediate therapy. And this is female gender, we cannot control. However, these are some factors can be modified by ourselves. So this high risk should be controlled very well. Decision to treatment for according to the triple size. So this size is matters. So bigger than 5.4. But in Korea, triple with the multiple risk factor and endovascular is indicated actually beneficial size 5.0 or above, and a little bit increasing with the time, generally can be reimbursed. 5.0 or above with the elderly patients usually can get reimbursement from the government. And the secular aneurysm, without the size matter, we can do the repair. However, the woman triple between the 5.0 to 5.4 centimeter surgical so we suggest repair. And the small aneurysm, but who require the chemotherapy or radiation therapy, the solid organ transplantation, this also require the multi-department decision-making approach. The timing of intervention, immediate repair for the ruptured aneurysm, that is definitely a strong recommendation. However, we should repair with symptomatic triple. It should be delayed to optimize co-existing medical condition. If needed, patient should be stayed and monitored in the ICU until everything is ready. When to intervene, elective repair, the size is increasing above 5.5 centimeter, and rapid expansion rate is important, and morphology belong to secular effusion with distal embolization or complication is present, and should consider risk factors for rupture. So, for example, the size is increasing, hypertension and COPD, smoking is coexist. And these are once the multiple risk is increasing, combined, then it's better to intervene earlier, repair. So the last content is the post-intervention care. So post-intervention, I don't care the open repair or the versus because the many data, the long-term, the open repair, of course, the numerically, the early mortality can be numerically different. However, the long-term, 5-year and the 7-year, the open repair versus endovascular repair, the outcome will not be so different. So actually, every outcome with the technical issue development and the device is becoming more nice. So actually, EVA is good choice. So EVA complication with the experience is more nicely accumulated, then we can reduce the complication also. These are the everybody experienced the known the evaluated complications. However, this can be reduced with the time, and we can prevent and manage it in many cases. However, at least we have to know and should be ready for the manage, especially the device-related complication. Everything we cannot handle right now, but at least during the procedure time, we have to be very careful for the medical therapy and the procedure itself. Endolic is most common, especially Taiwan, particularly during the procedure. So we can handle everything now, but the Taiwan is the most common, and this proper case selection is very important. The general oversizing should be enough, and we should case selection. So as I mentioned, too much hostile leg should be avoided. If something pre-procedural CT scan must be very important. Too much higher angle leg and too small, shorter landing zone, less than 50 millimeter, and the bigger neck diameter and the calcification and the organized thrombus. These are the main factor, and this neck appearance should be carefully considered before the decide. So the more the hostile neck component, the higher chance of stent migration, they can be associated with the morbidity and mortality. And the higher mortality and the device, the migration, the type 1 endolic. So we can overcome, especially the high surgical mortality, morbidity case, we can do this kind of something special preparation for the adjunctive expandable stent and the promise stent graft and the additional cuff and the chimney technique and the fenestrate endograft and the endograft system. So some examples and expandable stent like this hostile leg, and we can do something this hostile leg by the stent graft immediate type 1A endolig, and this kind of palmachas self-expanding very stiff short stent graft. Then we can see it perfectly. And the second example is we can do endo ankle system. Like these days, maybe you can use this endo ankle system. So the immediate type 1 endolig, we can do the screw endo anchoring and then the sealing of this endolig. And the additional cup is the self-expanding endograft. We can do this kind of hostile leg and the immediate type 1A and do the self-expanding stent graft. And this kind of one of my patients, very hyperacute hostile leg, this patient too much bad lung condition and the multi morbidity. So poorly indicated for the surgical procedure. So inevitably we had to do this kind of triple procedure. So main body first. This was the device was the Medtronic device, Endurance 2S, and main body first. Then did the definitely there must be this main body will little bit straighten over this acute angle portion, then rewiring from the contralateral, then did another cuff. So this portion we have to neglect, but at least this make it more straight, and this main aneurysm portion will be tightly fixed by the cuff. So ultimately, we have to finalize and reliant ballooning for the entire, then we can tightly fix this, preventing 1A endoleak immediately. And this will be neglect. And this huge aneurysm is nicely isolated after one more cuff. So another method is we can do chimney technique, but chimney is long-term also not so promising until now. The device limitation is always a problem. So actually in this year, I don't like the chimney. And fan is also too complex, so it's better to do the surgery. So hostile leg and the post-EVA imaging is also important. So post-EVA survey, to make it simple, I usually do 30-day CT follow-up. And if there's a suspicious of something not perfect imaging, suspicious of perfect sealing, then 6 months CT angio follow-up. If 6 months CT angio follow-up is not perfect, then 1 year CT follow-up, then annually doing CT follow-up if there's no endoleak in usual patients. But the no endoleak, the guideline recommendation is a sono follow-up, but it depends on the hospital situation. If the sonography specialty is not cooperative and the CT, unless the creatinine level is okay, and the hospital system CT follow-up is very, very easy and cost effective, then maybe we can do CT follow-up annually. And if no change with the CT, 1 year, 2 years, then maybe we can do just a simple sono follow-up, and we can make it more reluctant follow-up, 2-year follow-up or the 3-year follow-up with the post-EVA follow-up. So in summary, I think that earlier detection is very important to save our patients. So, however, I think the cost effectiveness is also important. So in Korean situation, I don't know the other Asian country, but our country, the nationwide insurance, they provide the abdominal sono annually, and the usual patients can get benefit from the routine nationwide health checkup. So many cases are coming from the early detection of imaging study. So we can do the automatic screening, and the self screening from the our personal clinic will be helpful with based on the guideline recommendation. And decision of timing, we have to think over the data and the guideline-based, size-based, rapid growing, the imaging data-based decision or the clinical setting-based decision for the intervention. And we have to properly decide whether the patient should go to surgery or go to EVA procedure. And post-intervention care and the follow-up schedule is also very important to monitor the patient safety and efficacy for the long-term durability. Thank you for your attention.
Thank you. Yeah, thank you, Professor Ra. Yeah, any questions that for the Professor Ra? Yeah, one quick question. She said, in your screening, in your private screening, I saw that you're screening actually with the patient with high risk patient. I see that you put the diabetics into your screening practice, but as far as I know, that diabetic seems to be really a protective factor for the infrarenal AAA cases.
Actually, the one US guideline, they say that there is a protective. However, I'm not sure that is from the large study. But as you know, our many real world patients, they have risk factors, and those risk factor patients share many proportion of diabetes. So when we excluding diabetic patients, that exclude all the risk, same risk of AAA patients. So it's a kind of a missense. So many of diabetic patients, they co-share the risk of AAA patients. So when I think of this AAA risk, many diabetic patients, nearly I think the 70–80% of diabetic patients share. As you know, the diabetic patients, nearly 50% of patients are premature coronary disease already, and they have, already many of them peripheral disease patients, and not only them, they have, dyslipidemia and hypertension. All they have risk factors share. So, from this point of view, practical point of view, I'm not sure diabetic they are really protective for the aortic aneurysm, and they are that is from the large study or not. I didn't investigate the search for the that is really fact or not. However, in my daily practice, if I remove diabetics from the surveillance, definitely there must be some lose of my patients. Yeah. That's why I left it.
Thank you. And the other thing is that I saw that you have a lower threshold to fix the AAA in patient with on the chemotherapy or radiation therapy. That's what I'm interested in, is that I think in my practice, I also do that, but I don't see too much evidence from that actually.
Yeah, that is a largely the specialist and the expert-based consensus from the guideline, and that it must be those patients must be very vulnerable, similar to connectivity issue or the inflammatory situation and something vulnerable patients. So there must be more chance of disease progression, the inflammation progression, and the size increasement chance, something like that. So I think that need a little more close follow-up and more rapid increase of diameter, something like that. So that must be case-by-case situation. We have to select the patients. So the more aggressive, the chemotherapy and the radiation therapy, and it depends on the cancer status. Every status must be different individually. So those impact on the patient situation and the aorta situation must be different among different situations. So we have to consider individually.
Yes. So, sorry, that may be misunderstood. I say that you had a lower threshold to treat this patient. I mean, probably 4 centimeters you treat this patient. Is that in your
practically in Korea, the nationwide insurance is very strict, not guideline directed managed. We cannot do that. Okay. So nationwide, thoracic aneurysm 5.5 centimeter or bigger can be reimbursed. AAA only 5.5 or above. can be reimbursed. So less than that size, we cannot treat.
Okay.
So 5.0 less with the chemotherapy, no. Even secular aneurysm, 5.0, we have to describe in detail. Oh, this is rapidly expanding, 4.0, secular, painful, quickly increasing, higher chance of rupture. You will be, if this patient is your father, you will be guilty and everything you have to describe on the report.
Okay, got it.
Then
size is the most, it's the only criteria basically. Size.
Yeah. That is a complex.
How about Followup? That did you do the AAA cases in a lower threshold in patient with chemotherapy or radiation therapy, or women, whatever?
For women, yes, but for chemotherapies or radiation, I think we have just limited number of the patients. So in my opinion, I still use the same number. But also we think about the survival of the primary disease of those patients.
Okay, got it. So Dr. Carlos, did you do the stent that in Abu Dhabi on your practice that?
Cardiac surgery doesn't do AAA, so that is our vascular surgical colleagues' domain.
So even in Abu Dhabi, you don't do that?
No, neither Abu Dhabi nor in Europe. I think also in the US, it's separate.
Got it. Okay, so very, very nice and appreciates everybody's staying up to so late. What time is it now in Abu Dhabi now?
Nice lunchtime. It's about 1 o'clock.
Oh, so it's lunchtime, but in Korea it's 1 hour late, right? Now it's about 5, almost 6.
Korea, almost 6 p.m.
6
Yes,
p.m.
Korea is plus 4.
Okay, we are in the same time zone, so we are now about 5. Okay, so very appreciate that everybody's staying up to now. I think the time is up, and thank you, Professor Rao, Professor Warawang, and Dr. Carlos, and please forward my message to Uma.
I will.
Yeah, thank you. And Professor Ling, I think that we are gonna to end this session. So thank you for everybody's join.
Have a nice day.
Professor Ling, you have any comments on the last?
No, thank you for all your contribution to this webinar. It's very successful. It's a very good interaction between cardiologists and cardiosurgeons. It's really unusual occasion. Thank you all. Thank you all for your contribution. Thank you.
Okay,
thank you very much.
So we're gonna end it up. Okay, see you.
Thank you.
Okay, bye-bye.